Good morning. Today our topic for discussion is the vertical jaw lesion. So it is basically a maxillomandibular relationship. It is the any spatial relationship of maxilla to mandible or infinite relationship of mandible to maxilla. So it can be of it is of three types. That is orientation jaw relation, which is the relation of maxilla to the base of skull. Vertical jaw relation, that is the height of face determined by the amount of separation of jaw under specific condition. And horizontal jaw relation, that is the anteroposterior relationship of mandible to maxilla. So today we will be discussing about the vertical jaw relation, the different methods to determine vertical jaw relation. So coming to the definition, it's the degree of separation of jaw or the vertical height of face. It can be classified into three, that is the vertical relation at rest, at occlusion, and in other position of mandible. So coming to the first one, that is the vertical dimension at rest. It is the length of face when the mandible is in rest position. Vertical dimension of occlusion, that is the length of face when the teeth are in maximum intercuspal position. So coming to the method to determine the vertical dimension at rest. So before going to the different methods, there are certain criteria we should take into consideration while we record the vertical dimension at rest. That is, the patient should sit erect with upright with the head erect and looking straight. Then coming to the patient should be relaxed. Where if the patient is tensed or if the patient is not relaxed, it is difficult to attain the vertical dimension at rest. So always make sure the patient is not nervous. He should be in a relaxed form to identify the vertical dimension at rest. And neuromuscular disturbance, such a patients lack coordination, right? So it will be difficult to attain the rest position. So the dentist have to spend more time with the patient to attain a rest position, and to record it, it will require some time. And duration, even though it is a recordable position, but the patient could not hold that in that particular position for a long period of time. So whenever the patient attain a rest position, the dentist have to make the or measure the take the measurement. Then use of several methods, that is a combination of different methods will be required to identify the correct rest position. So it's a combination of different methods. So coming to the methods to determine the vertical dimension at rest, that is there is two types, that is facial measurements is the, then anatomical landmarks is the. In facial measurements, we will be placing 2 points that will be on the tip of the nose and prominent point on the chin, which will be marked with a CD pen or CD marker on a adhesive tape. And we'll be measuring the distance between these 2 points using a divider or a Will's gauge or tachometer. And to attain a rest position during this, we can use following method: tactile sensation, phonetics, and facial expression. And using these techniques, we'll be taking the measurements of between these 2 points and measurements of the anatomical landmarks. We'll go that into details. So first one is the facial measurement. So first of all, as I said earlier, in this picture we had put 2 points, which is on the tip of the nose and prominent point on the chin, and we'll be measuring the distance between those 2 points. So this is the Will's gauge used to make the facial measurements. First method is the swallowing method. So for this, ask the patient to droop the shoulder, that is to sit in a relaxed position, wipe his or her lip with tongue. Then ask the patient to swallow and close the mouth. Then during if the patient do this, the patient will attain a rest position, and at this point of time you can take the measurements between the points. And tactile sensation, often ask the patient to open the mouth wide, that is and ask to hold it for 1 to 2 minutes. until he feels so strained. Then ask the patient to close slowly so that he feel comfortable at some point, and relax. Make the measurement in that point. That is the tactile method. Next one is the phonetic method, which we use commonly. So ask the patient to repeatedly say the word M. So as the lips come in contact, ask the patient to stop the pronunciation of the letter M and make the measurement. Next one is the facial measurements. With the appearance of the face, we could able to identify whether the patient is in a rest position or not. So for that, ask the following features indicating of the relaxed position. So the lips are even anteroposteriorly with a slight contact. Skin around the chin and the eyes are relaxed, and nostrils around the skin around the nostrils are in a relaxed state with unobstructed breathing. All this indicating of facial expression indicative of the patient is in a rest position. Coming to the anatomical landmarks, that is proposed by Will's Gate. He proposed that the distance between the angle of pupil of the eye to the remoris, that is the corner of mouth, will be equal to the distance from the anterior nasal spine to the lower border of the mandible. So this two distance, if it is equal, that means the patient is in a rest position. So by all this method, we can use the combination of some methods to identify the rest position. So we identify the rest position. Now coming to the vertical dimension at occlusion. For this, we have again two methods. That is the physiologic method is the mechanical method is the. Coming to the physiological method, there is Nisswanga method, swallowing threshold, phonetics, neuromuscular perception, aesthetics. Mechanical method, ridge relation, pre-extraction record, and measurements from the former denture. So coming to the first method, that is the Nisswanga method, which is the commonly used method. In that, Nisswanga states that the vertical dimension at occlusion will be less than that of the vertical dimension at rest. That is, but if the equation is like vertical dimension occlusion equal to vertical dimension at rest minus freeway space. That is 2 to 4 mm will be the freeway space. So how will you do this? Then initially you have to insert the upper occlusal rim, correct the incisal visibility and fullness of the occlusal rim should be corrected. After that, plane of the maxillary rim is corrected. After that, we establish the vertical dimension at rest. Once that is done, we have to contour the mandibular occlusal rim in such a way that it should come in contact with the upper occlusal rim evenly, and if a difference of 2 to 4 mm should be there. That is, the vertical dimension at rest should be, if it is 60, the other one at occlusion should be 57 or 56. Which we should adjust the rim until we get a freeway space of 2 to 4 mm. So that is the Nisswanga method. This is the same thing which I explained. The lower rim is adjusted till the 2 to 4 mm freeway space is obtained. So this picture indicates the vertical dimension at rest and occlusion. The smaller gap between the this indicates first picture shows the freeway space. Now next one is the swallowing threshold. In this technique, the concept was like a light contact of the rim will be there and during the initial cycle of swallowing. So in this method, we use a small cone of soft wax is placed on the mandibular occlusal rim when the jaws are in open position, and we stimulate the swallowing cycle. We stimulate the salivation with a piece of chocolate or something, and as it is a soft wax, it will get reduced in height and come into contact at the point when the two jaws are in contact position. The lower cone is softened and the patient is asked to repeatedly swallow. So this will gradually reduce the height of the cone of soft brax, and this will the lower rim, the lower and the upper occlusal rim will come in contact at the occlusal position. So we can identify the vertical dimension at occlusion. Now coming to the closest speaking space, that is proposed by Earl Pound. He said that there should be a gap of 1 to 2 mm between the incisal edge of maxillary and mandibular anterior teeth when the patient says the word S, pronounce the word S. So it was initially it was called as the closest speaking level by Silverman. Later it was said that closest speaking space. We can also use the letter CH or J sound, also bring the anterior teeth closer. We can also determine the distance between the incisor tooth by pronouncing such words. If the distance is too large, that indicating of the smaller vertical dimension, and if the teeth are coming in contact, that indicating there is an increased vertical dimension. So this picture shows a small space between the anterior teeth when the patient pronounces the word S. Coming to the central bearing device, that it consists of two things, that is a central bearing plate and a central bearing screw is there. Both will be attached to the maxillary and mandibular occlusal rim in such a way that the screw is set in a high position, that is in an increased vertical dimension, and slightly we have to decrease the height of the screw until the patient feels comfortable. So that position is the vertical dimension at occlusion. So there is a problem with this method. There is a foreign object will be there in the palate and there will be restriction in the tongue space. Coming to the next neuromuscular method, that is the power point or maximum biting force. It was proposed by Boos in 1940. So he said that there is the maximum biting force will be at vertical dimension at rest. So we used attached a pressure indicating gauge to the central bearing plate. So by that method, the instrument is known as bimeter, and the maximum biting force is the power point. And the screw is adjusted such a way that they come in contact, and Boos states that the vertical dimension at occlusion in rest is the rest position or maximum biting force minus 2 mm. So this picture indicating of the center bearing device with a pressure indicating gauge attached to the center bearing device. Coming to the aesthetic method, when there are certain features that will be appeared when the vertical dimension is increased. The skin appears to be stretched, and if the vertical dimension is less, the skin appears to be flaccid. And also the contour of the lip and the fullness of the labial contour all will be affected by the increase or decrease vertical dimension. By assessing that, we could able to identify the proper vertical dimension. So this picture indicating of increased vertical dimension which affect the aesthetic of the patient. Coming to the mechanical method, that is the ridge relation. First one is the incisive papilla to mandibular incisor. There should be, he states, theory states that there should be 4 mm distance between the incisive papillae to the mandibular anterior teeth. So, but this is not an accurate method, as because of resorption there will be a change in position of the incisive papillae. So it is not a proper accurate method to determine the vertical dimension. Next method is the ridge parallelism. Again, we could able to check the parallelism between the maxillary mandibular tooth, but usually the maxillary mandibular tooth extraction, if it is on the same time, that will give a parallel edge, but in most of the patient, the extraction of different tooth will be done in different times, which will so by the time when the patient become edentulous, the ridges won't be parallel to each other. So again, this is not an accurate method to determine the vertical dimension. Next one is the pre-extraction record. That is any kind of the records. Maybe it is of photograph, chill outs, or radiographs. All that taken before extraction can be used as a index or a reference for the reference of the while we are doing the jaw relation or establishing the jaw relation. So coming to the first one is the profile photograph. We can take the photograph of the patient before extraction, and we can enlarge that into a life-size photo so that we can compare the aesthetics or during the while we are doing the jaw relation. So in this picture, the photograph of the patient is done before extraction, and which can be compared while the jaw relation by placing the occlusal rim, whether the fullness or the contour is correct or not, if the skin around the lip or no chin appears to be stretched. All that can be compared with the photograph. Coming to the profile chill outs, the profile of the patient with natural tooth in occlusion before extraction can be carved in a cardboard or contoured in a wire, and we can place it on the face when we are doing the jaw relation for a comparison. Coming to the radiographs, again, cephalometric radiograph and radiographs of the condyle has been used. Before extraction can be used, and we can use it during the recording of jaw relation. Coming to the articulated cast, mounted cast before extraction can be compared with that of the jaw relation that we are done. Then facial measurements. It is 2 tattoos are placed on the upper part and lower part of the face. A measurement is done, which is again correlated while we are doing the jaw relation. If the measurements are same or not, we can compare that. This is the picture. 2 tattoos are placed on the upper and lower half of the face before extraction of teeth, and we could able to verify the jaw relation, vertical jaw relation. Coming to the third method, that is the measurement of former denture. We can place the old denture in patient's mouth and establish a vertical dimension. And same can be compared with the new denture, or while we are doing the while we are establishing the jaw relation. Now coming to the effect of increased vertical dimension, there are certain problems which will be caused to the patient if there is an increased vertical dimension. First one is a discomfort. So that is the patient will be having a chewing cycle which will be developed over many years. That is that will occur unconsciously. So this movement again take place when we place the denture. So if there is an increased vertical dimension, there will be contact of the tooth, premature contact of the tooth, which will cause discomfort during the chewing cycle. And the trauma, again, the premature contact of the tooth can cause trauma to the denture bearing area, especially under the lower denture, as the area to the force dissipation is less. Then TMJ problem, the premature contact can cause soreness and pain. Come to the bone resorption, if there is an increased vertical dimension, the muscle close to the mouth to complete their contraction. This will cause excessive force to overcome the obstruction. As the vertical dimension is more, they cannot close the mouth fully, so which will cause increased stress and this will lead to resorption of the supporting tissue. Then muscle fatigue, as the constant effect of the muscle to close the mouth, muscle fatigue will occur. And clicking of the teeth, premature contact, which will cause teeth come in contact with the opposing sooner than the expected time, so which will cause the clicking of the jaws. Then facial distortion, there will be an inability to close the lip. So this will produce a strained appearance or elongated face. And again, there is difficulty in swallowing and speech. Effect of decreased vertical dimension, there is decreased biting force, which will cause inefficiency in mastication, and there is flabby cheeks will be produced because of decreased vertical dimension, which will cause cheek biting, and the patient will be having TMJ problem, pain, and clicking will be there in the TMJ, and facial appearance will be altered. There is loss of lip fullness, tonicity of muscle will be lost, flabby appearance of the face will be there, and the patient appears to be older, as there will be wrinkles because of decreased vertical dimension. There is pooling of saliva, which will cause increase, which will be an ideal place for the bacteria to grow, and there will be infections over that. So all this will be caused during the decreased vertical dimension. So hope you all understand today's class. Thank you.